Thank you so much. Thank you, APSA colleagues and the Program Development Committee for the opportunity to speak today. I plan to explain why pediatric surgeons are important advocates for fertility preservation in children with cancer. Due to the dramatic increases in survival and cancer therapy over the past 30 years, today, 7 out of 8 children with cancer will survive. Adult survivors of childhood cancer experience late effects of treatment. Infertility is cited as the most significant long-term quality of life issue for adult survivors. Multiple professional societies, including the American Academy of Pediatrics, the American Society for Reproductive Medicine, and the American Society of Clinical Oncology, recommend a discussion of fertility preservation options for every patient prior to undergoing gonadotoxic chemotherapy. Overall, we have room to improve in how we educate patients and families about infertility options to preserve fertility. Anna Zotto and colleagues, in a recent systematic review of worldwide practice, found that pre-treatment discussion of fertility preservation options ranges from 9 to 78%, depending on country, location, type of hospital, and that patients and families initiate the discussion in 23 to 50% of cases. So, what are the options? Post-pubertal and adult males can bank sperm because they produce mature sperm after puberty. However, prepubertal boys produce immature spermatocytes, and testicular tissue cryopreservation, or freezing of testicular tissue, is the only option available prior to treatment. This is an experimental option and requires testicular biopsy. Postpubertal girls and adult women can bank embryos because they produce mature eggs. However, many postpubertal girls cannot undergo the 2 to 3 weeks of hormone stimulation necessary for egg harvesting, and embryo banking is not an option for pediatric patients for legal and ethical reasons. Prepubertal girls have ovaries which contain their entire supply of follicles, just over 1 million primordial follicles at birth, and these will decline over the lifetime of the female to reach 1,000 to trigger menopause at around age 50. Ovarian tissue cryopreservation, or freezing of ovarian tissue, is the only option available for fertility preservation in prepubertal girls. It is considered experimental and is achieved by surgical unilateral oophorectomy, typically with a laparoscopic approach. Alkylating chemotherapy, radiation, and stem cell transplant protocols place patients at the highest risk for infertility due to direct toxicity to the growing germ cells and to depletion of the primordial follicle pool. This is why males experience azoospermia and females experience premature ovarian insufficiency, which is menopause symptoms 15 to 20 years earlier than expected due to reaching the trigger point of 1,000 follicles earlier than expected. This graph depicts depletion in the primordial follicle reserve that occurs in a 10-year-old with 12 gray of radiation to the abdomen, and menopause symptoms ensue at approximately 19 and a half years. This flow chart demonstrates the options for prepubertal girls being ovarian tissue banking and postpubertal girls who are not able to undergo hormone stimulation. This flow chart demonstrates the options for prepubertal boys being, trying to find the pointer here, being testicular biopsy, and for mature post-adolescent males to bank sperm. In 2014, the American Academy of Pediatrics Surgical Advisory Panel recommended that patients 5 years or younger who may need surgical care should be cared for by a pediatric surgeon, and that minimally invasive procedures in infants and children should be performed by a pediatric surgeon trained in those techniques. We are trained to do laparoscopic oophorectomy in children and testis biopsy in children. This photo shows a laparoscopic review of a 2-year-old female during unilateral oophorectomy for ovarian tissue cryopreservation. Note the thin ovary on a long fallopian tube pedicle, the small size of the pelvis, and the very small size of the ovary. And yet, that ovary contains hundreds of thousands of primordial follicles. This photo is an intraoperative view of a testis biopsy in a 2-year-old. These are straightforward outpatient procedures that ought to be performed safely with excellent hemostasis, delicate handling of the tissues, and no delay to definitive medical therapy. Pediatric surgeons often have early involvement in patients with a new cancer diagnosis through mass resection or biopsy, through lymphadenectomy, through central venous access. We can advocate for early fertility preservation education through discussion with our colleagues as treatment plans are developed. We know that certain protocols with cyclophosphamide equivalent dose, or CED, of greater than 4 grams per meter squared in males and post-adolescent females, and radiation to the abdomen and pelvis place children at significant risk for infertility. Families indicate that they want fertility preservation education regardless of the infertility risk, but we should absolutely ensure that those patients at highest risk, 80% or greater, understand that and understand the options. Thinking about limiting anesthesia exposure by combining procedures under one anesthetic and avoiding delay in medical therapy are critical and require fertility preservation counseling and education early to plan for that one anesthetic exposure at the same time of the venous port insertion, or to plan to do the procedure after 1 or 2 cycles of therapy at an appropriate time and prior to the patient receiving high gonadotoxic doses. Again, the 80% or higher risk, and then 20 to 80%. In general, 50% or higher and a survival of at least 5 years are criteria for surgical fertility preservation option in a prepubertal child. This is real, and the future holds great promise for our pediatric patients for fertility preservation and restoration. Since 2004, when the first pregnancy was achieved after reimplantation of ovarian tissue, there have been over 130 live births worldwide. This has prompted many adult providers to recommend removing the experimental label for ovarian tissue cryopreservation, and some pediatric providers have also begun to advocate that so that we allow just access to the procedures for pediatric patients. In 2016, in London, a 24-year-old woman gave birth to a full-term baby using ovarian tissue which had been cryopreserved at age 9 years prior to bone marrow transplant for beta thalassemia. Her tissue had been cryopreserved for 13 years, and she displayed signs of early menopause indicating premature ovarian insufficiency in her 20s. Recently, in a very important scientific discovery, a baby primate was born using prepubertal testicular tissue, which had been cryopreserved and then reimplanted and matured. A 3D printed bioprosthetic ovary is another important recent discovery, which has resulted in birth of mouse pups from follicles implanted into the ovary. This could be an important option for our pediatric patients in whom it would not be safe to reimplant whole tissue due to risk of reimplanting malignancy. One thing is for certain. Our pediatric patients have the advantage of time and rapid scientific progress regarding both their cancer treatment and their long-term quality of life issue of infertility. We can do our part by ensuring that our patients receive appropriate education to understand the options and by participating in safe surgery for fertility preservation whenever we can. Thank you, and I'll be happy to answer questions.